हेलो दोस्तों, फर्स्ट ऑफ ऑल I would like to wish you all the best for the exam. You have worked all throughout the year. You have sacrificed so many things. Your hard work, your sacrifice will definitely bring good results for you. At this point of time, have faith in yourself. You can do. You are a champion. You will do well in the exam no matter what happens. Okay, so stay calm at this moment. Staying calm is the best thing that you can do, is the best thing that you can do to perform the best in the exam. Don't create so much hype about the exam. कल तो मेरा नीट का एग्ज़ाम है, इस पे ही मेरी सारी ज़िंदगी निर्भर है. नीट एग्ज़ाम is not everything. The more you take it as a normal exam, the better you perform there. So do remember this thing. The normal you take the NEET exam, the better you perform in the NEET PG. Okay, so we will spend our day as we have spent the earlier days. Okay, we will not think too much about the exam. Now few exam tips that I want to give you is that you have to attempt more than 290 questions. I know you are scared of negative marking, but friends, if you leave more than 20 questions or 30 questions, you are already out of the league. So don't do this mistake of leaving so many questions. Attempt more than 290 questions. Okay. And the second tip that I want to give you is that you have to stay calm. Even if there are 10 to 20 questions in a row that you don't know, then also don't give up. Those 10 to 20 questions are for everyone. Even if there are 50 questions that you don't know, 70 questions that you don't know, stay calm. Okay, try to attempt them because leaving the questions is not an option. Third tip that I want to give you is complete your paper in time. The main reason that we don't complete the paper on time is because we spend too much time on the questions that we don't know. So keep the questions that you don't know, that you have doubt, for the end. At least 50 questions, 50 to 60 questions, you keep it for the end, not more than that. And the last tip that I want to give you is that don't change the answer of the questions in which you are 50-50 sure. Go with your intuition, go with your first intuition that comes to your mind. If you have because many times what we do, we tend to change the answers of the questions that are already correct, that are right. Okay, so you will not do this mistake. But if you find any gross mistake that you have done, you change the answers for those questions. Okay, so now we will revise retina. Electroretinography. A wave, B wave, C wave represents. A wave is generated by photoreceptors. B wave by Muller cells and bipolar cells, and C wave by retinal pigment epithelium. Electrooculography is used for the function of retinal pigment epithelium. In this, we calculate Arden's ratio, which is normally more than 1.85. In Best's macular dystrophy, this ratio comes out to be less than 1.5. Dot blot hemorrhages are seen in outer plexiform layer. CSME, clinically significant macular edema. In this, retinal thickening is seen within 500 micrometer of center of macula, or exudates are seen within 500 micrometer of macula. Okay. Hypertensive retinopathy. In grade 1, you will see narrowing of retinal arterioles. In grade 2, Salus sign, that is deflection of veins at AV crossing. Grade 3, Bonnet sign, banking of veins at AV crossing. Gun sign, tapering of veins at AV crossing. Grade 4 is papilledema. Also in grade 3 comes the copper wiring of arterioles. And grade 4 also includes silver wiring of arterioles. In CRBO, you see tomato ketchup appearance, so this is tomato ketchup appearance. CRAO, you see central retinal artery occlusion, you see cherry red spot. Cherry red spot is also seen in, trauma, Niemann-Pick disease, GM1 gangliosidosis, Tay-Sachs disease, Sandoff's disease, metachromatic leukodystrophy, and Gaucher's disease. You can remember it with the mnemonic: Christmas tree never grow tall in sand, mud and grime. Christmas tree never grow old in sand, mud and grime. Okay. So coming to Coats disease. Coats disease is idiopathic retinal telangiectasia, central serous retinopathy. It is localized shallow neurosensory detachment at the macula due to collection of fluid in subretinal space. You see smokestack appearance on fundus fluorescein angiography. In cystoid macular edema, you see flower petal appearance on fundus fluorescein angiography. What is cystoid macular edema? It is leakage from perifoveal capillaries, retinal capillaries, and accumulation of fluid in outer plexiform layer and inner nuclear layer. Okay. Coming to age-related macular degeneration, it is of two types, dry and wet. In dry, you will get choroidal neovascularization and or pigment epithelium detachment. In early and intermediate dry ARMD, you will get drusen's. In late, you will get geographic atrophy of retinal pigment epithelium. In early and intermediate, you will get drusen's. In late, you will get geographic atrophy of retinal pigment epithelium, and in the wet ARMD, you will get choroidal neovascularization. Angioid streaks, you get spider web appearance. Okay, and it is seen in pseudoxanthoma elasticum, Ehlers-Danlos syndrome, Paget's disease, sickle cell disease, idiopathic. Just remember pseudoxanthoma elasticum, that is the most important. Retinitis pigmentosa predominantly affects rods, and with subsequent cone degeneration, you get bony spicule formation in the peripheral retina. So this is how bony spicules look like. Okay. Systemic association of retinitis pigmentosa, you get Kearns-Sayre syndrome. In this, there is ocular myopathy and heart defects. In Usher syndrome, there is labyrinthine deafness. In Bazin-Conway's syndrome, you get retinitis pigmentosa, A beta lipoproteinemia, and acanthocytosis. In Best macular dystrophy, you get vitelliform lesions. Okay, and on EOG is always abnormal and Ardens ratio is less than 1.5. You need to remember the causes of rhegmatogenous retinal detachment, tractional retinal detachment, and exudative retinal detachment. In rhegmatogenous retinal detachment, the causes are pathological myopia, lattice degeneration, blunt trauma, cataract surgery. So question can come, cataract surgery, what type of retinal detachment occurs? Pathological myopia, what type of retinal detachment you see? In tractional retinal detachment, it is seen in proliferative diabetic retinopathy and sickle cell retinopathy. Exudative retinal detachment, it is seen in choroidal melanoma, Coats disease, and CSR, central serous retinopathy. Last, you remember the causes of leukorrhea. It is persistent hyperplastic primary vitreous, toxocariasis, endophthalmitis, retinopathy of prematurity, retinal detachment, retinoblastoma, Coats disease, coloboma, cyclitic membrane, cataract. Okay, so thank you friends for watching this video and all the best for the exam. Do well, do great.